Welcome to SDHC's Health and Wellbeing podcast. Before we begin, we want to emphasise that the information shared in this podcast is for educational and informational purposes only. While we strive to provide accurate and up-to-date content, it is not a substitute for professional medical advice, diagnosis or treatment. Always seek the guidance of your doctor or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. Remember, your health and well-being are invaluable, so prioritise consulting with a medical professional for your personalised care. Hi everybody, you're listening to the Health and Wellbeing podcast from Health and Wellbeing and SDHC with your host Dr Nick Harvey. The purpose of the show is to help people understand how they can help themselves and others with their health and well-being. Every episode I interview an everyday expert to understand the latest evidence and advice on how to improve your own health or help others. Joining us on today's podcast is Dr Olivia Hum. Dr Olivia is an experienced GP and has been a GP partner at Foundry Healthcare in Lewes for the last 16 years. She's trained at Cambridge University and UCL Medical School and has worked in Australia and East Timor. Dr Hum specialises in perimenopause and menopause, hormonal health, contraception and sexual health. She holds the FSRH Advanced Certificate in Menopause Care, training at Guy's Hospital Menopause Clinic. One of the 240 British Menopause Society menopause specialists in the UK and a BMS trainer. She's on the British Menopause Society Medical Advisory Council and is actively involved with national pathway design and guideline production. A member of the RCGP Adolescent Health Group, which exists to help support GPs in developing health services for young people, Dr Hum is also a GP trainer and appraiser, teaching and supporting junior GPs and GP trainees. Dr Hum prides herself on offering a holistic service, looking at not only physical but also social and psychological aspects of health. She's passionate about improving healthcare for women, especially around the menopause and perimenopause, where so many women are suffering needlessly with debilitating symptoms. Welcome, Olivia. Goodness, I'm exhausted reading all of that. And I bet sometimes you've got to pinch yourself, really, given how much experience you've developed over the years.
Yeah, I mean, it's been really great. And, as you know, the great thing about being a GP is having that really generalist approach. So being able to do bits of everything, but also it's really nice to be able to narrow down and specialise a little bit more as I get into sort of the last bit of my career.
Absolutely. Yeah. So before we dive into that, just tell us a bit about yourself.
So I mean, a lot of it was in that first paragraph. So I'm a GP and so I work in Lewes and I've been there for, decades. So that's where I trained in Brighton as a GP and that's what I've been doing. But I've always specialised in women's health and sexual health. So about 14 years ago, I set up a young person's sexual health clinic in Lewes called the Circle Room. And we see young people from all over Sussex, under 25. It's just a drop in. And then that really and then obviously as I got older, my patients get older too. And you start seeing a lot more women's health. And then obviously about, 7-8 years ago, we started getting a lot more people coming in talking about menopause. And that's what really I started thinking, wait a minute, we're not doing this very well. So what we're telling women isn't actually true. So I started doing a lot more research. And that's when I started doing the advanced certificate, the sort of advanced training in menopause then.
Fantastic. Because I think you mentioned before we went on air, really, there's a bit of a menopause revolution that's happened, hasn't it? And it's really impacting all of us in primary care. So expand a little bit on that and what's happened and why are we suddenly a bit more aware of the menopause? So, I mean, it's been what we don't realise, what a lot of us don't realise, is that actually before the 2000s, a lot of women were on HRT. So it was people come in, HRT was the big thing. A lot of women were on it. And then suddenly in the 2000s, there was this trial which was released that linked HRT with breast cancer. And I remember this well, actually. It was in the 2000s. I was a junior GP and literally overnight women stopped their HRT. The MHRA issued a big warning. So GPs weren't allowed to prescribe HRT. We were supposed to tell women it was really dangerous. And women didn't want it. And so for about 2 decades, that was the status. And so none of us were very experienced in prescribing it. And then suddenly what happened is that there was a big social change, I think. So the initial trial was reevaluated.
the results came out showing that actually it wasn't as dangerous as we thought. And actually the newer preparations of HRT, which are around, were very different from the older ones in the trials. And then I think women started talking about this on social media and started asking their GPs, and GPs started realizing that they were having to upskill. And then, of course, it was the Davina McCall documentary, which was in 2021, which was the real, absolutely blew this whole thing wide open and everything. And I run a big doctors forum for doctors interested in menopause. And what happened is that we went from something like 80 members to about 4,000 members overnight. And people started, definitely female GPs especially, started finding that they were just seeing hundreds of women coming to them to talk about menopause, which we'd literally never really seen before.
Mm-hmm. Talking about women as well, I heard this week that there's more female doctors than male doctors, which is fantastic to hear, isn't it? And is that what's inspired you here? Because I think as a male doctor, I don't get that many patients coming to me with those kind of symptoms. Is that really what drove you to look at this? Because you're just getting all the female patients coming to you with these problems, and actually you're in a minority as a female doctor at that time. So you must have been overwhelmed, I imagine.
Yeah, and definitely even now, I think if you talk to any female doctor, so what happens now in many practices is you've got one doctor or one advanced nurse practitioner who sort of specialises in menopause, and that actually even in my NHS practice occupies most of my day now. It's something that we do an awful lot of. And I think that was what pushed doctors to have to suddenly upskill very fast, was that they had the demand from patients. But also it's been really aware that it's not done very well. And the reason why, and again, I've worked a lot now with gynecologists sort of at the British Menopause Society, and actually gynecologists don't cover menopause in their training at all. It's not something that they do. So the majority of gynecologists know very little about menopause. And it means that many GPs are very isolated. So if you are seeing a patient that is complex, you literally have no one to ask. So the local gynecologist, definitely around here, we don't have any specialists. And actually, so you ask a question to a specialist and you get an answer back and you think, actually, I don't think that's correct. And so GPs were feeling very isolated. And this is one of the reasons I joined the British Menopause Society. So when I joined, there weren't any other GPs on the council. There are a few now. But what I was really pushing for is that actually primary care needed really good sources of education. And that's what we've been doing at the BMS, is really supporting GPs and primary care by delivering really good guidelines, evidence-based guidelines, but also doing lots and lots of teaching. So I do teaching all over the UK to GPs.
And there's also some amazing resources on the web now, aren't there, as well? Are you behind some of those?
So the ones that we'd really recommend, so the British Menopause Society resources for doctors are fantastic. So they are the synthesis of all the available evidence. And obviously in a lot of areas, there isn't much evidence. So we are working outside evidence and outside license, but the BMS stuff is pretty, and I see the pain and the debate that goes into it. So that is the best information that you're going to get. For patients, the Women's Health Concern website is the patient branch of the BMS. And so there's lots and lots of information on there for patients. And again, that is all evidence-based. I think for patients, unfortunately, nowadays, there is so much information out there, and a lot of information has a commercial background behind it. So I'm 50, your algorithms essentially on social media spend their whole life sending you supplements and exercises and this, that and the other, a lot of which are quite expensive. And women don't know who to believe anymore. They don't know who to trust. We've gone from no information 5 years ago to way too much. So what the BMS does is tries to kind of just offer really good evidence-based guidelines.
Mm-hmm, mm-hmm. It's tricky, isn't it, when there's an overpopulation of evidence and advice? People get very confused and probably more likely to make bad decisions, aren't they? So I guess some of your role is kind of limiting the choices a little bit. Is that?
Yeah, absolutely. And so as part of my menopause work, I also do private menopause care at Myla Health. And we have the absolute joy of getting an hour with each patient, which is just, as we all know as GPs, if you had an hour with each patient, no one would ever be able to get an appointment, but you'd be able to do so much more. And actually a lot of what women are coming to us for is just simply to have a really good evidence-based discussion. What are the risks and, what are their symptoms? Are their symptoms menopause or not? What are the risks and benefits to them of different kinds of treatment? And that a lot of the evidence base is quite lacking. So what we're going on is consensus and guidance, essentially.
Sure. You also mentioned just earlier about things being off license. Do you want to just explain that to anyone who's non-medical?
Yes, absolutely. So this is something that I've had to really learn about. So when a drug is licensed by a drug company, then they will test it on a specific population in a specific way. And then they will apply to an organisation called the MHRA in the UK for a licence. And so HRT is licensed for postmenopausal women. So women who are postmenopausal, who have had a year since their last period. And they're quite simple to treat often. But the big confusing time is perimenopause. And perimenopause is this time leading up to menopause in which women's hormones are very unstable. And HRT is not licensed for use in perimenopause. So when we are using it, there's no evidence that's governing our use. We're going by what we think might work. We're going by what we know about the human body and about the physiology of how women's hormones work. But actually, there's no real rules or guidance. So we are allowed to prescribe as GPs off license. And we do, for instance, in children. A lot of the drugs we prescribe for children aren't licensed because you can't do experiments on children. So often a lot of these drugs we're using aren't licensed. Drugs we use, for instance, for pain, we sometimes use things like antidepressants for pain relief, even though that's not licensed either. So we are allowed to use drugs off license, but it does make it a little bit more complicated in terms of how we use them.
Sure. Thanks for that explanation. So, in terms of patients, they must come to you with all sorts of different symptoms. But what's your message to women who are thinking, maybe this is menopause, or maybe that's not even on their radar because there's so many symptoms that they can suffer from. They might not even be thinking of menopause. So what's your message to people around that age, I guess, as to, the help they seek?
I mean, it's really difficult. And I think there's some sort of worry in the menopause world that the pendulum has swung so far in the other direction that we're now getting people attributing every symptom to perimenopause or menopause. Well, we know that the really annoying thing is about perimenopause and menopause is they happen at a time where women also have a lot of other things going on in their lives. So we know that women in their 40s now are likely to have quite young children. A lot of women have had children a lot later than they used to before. We know that often it's an age when your parents are getting older. So you've got that strain as well of having to look after elderly parents. They're what we call the sandwich generation. We know that women are now working at higher levels in jobs than they ever were before. So are trying to often juggle home and work life in a way that they weren't before. And then it's very difficult to tell whether your tiredness and anxiety and brain fog is caused by the fact that you're utterly overwhelmed by all the stressors that are put on you, or whether it's actually hormonal. So one real tell in perimenopause, so often the first signs of perimenopause are cycle changes. So people will often find their cycle gets shorter or their periods change. And often they start getting symptoms just before their period, which is when their estrogen level drops. And so if there's a cyclical nature to symptoms, so often it's anxiety before your period is the first one that we see. Some people get sleep disruption or all these other different symptoms. Then that's often a real teller to us when we're seeing patients to say, actually, maybe there is a hormonal component to this. I mean, clearly the one that everyone knows about is hot flushes, but actually you usually had a few years of hormonal disruption before the hot flushes kick in.
Thank you. And I guess the other thing is that with HRT coming up, it does feel sometimes like women might be disempowered in the sense of you've got to go through this gatekeeper who's your GP, or you can afford to go privately to somebody to prescribe. So what are the other options that are out there?
So there are other options. And again, everyone in their 40s, any woman in their 40s is being absolutely deluged with them. But the thing to say is that the 40s and 50s, or what we call midlife nowadays, is a real changing point in women's health. So what happens after menopause is this is when our cardiovascular risk starts catching up with that of men. This is when our bones start declining in density. This is often a time when women, they're out of the trenches of having very young children and are starting to think about themselves again. And it's often a time when women start looking at their health. So what we really try and encourage is that it's not just about HRT. It's about optimizing overall health. It's about thinking about things like alcohol and smoking. And these are times to start that they're really, you are going to start getting the damage from this. This is the time to start thinking about it. Exercise, we know it's just so important. We know it reduces menopausal symptoms. It helps mental health. It helps sleep. It helps with the weight gain that many women get around perimenopause and menopause, and it helps with your bones. So all of these things we need to be encouraging. With things like supplements, again, whenever we do lots and lots of talks for patients. And the first question is always, what supplements should I be taking? And the answer is there's no evidence base for any of them, apart from vitamin D, which we should all be taking in the UK because we don't make enough in the winter. But apart from that, realistically, what we're trying to encourage people is to manage their symptoms if they want to with healthy diet, exercise, fresh air, all those other kind of things. But actually, there's no point. What we don't do is delay HRT. So, for instance, when we're treating people's blood pressure, we'll often say, why don't you try lifestyle for 6 months and then we'll have a look at medication. Actually, if women are getting menopausal symptoms, the evidence shows that actually you can give them HRT alongside the lifestyle changes. It doesn't have to be one or the other. But it's not HRT for everyone. Some women don't want to take HRT. And I think luckily the days where women were being denied it by their GPs it seems to have really changed. I see a lot of women. So I work at the women I see from around here. I see at the Nuffield in Brighton. And we really get an idea of what GPs are doing. And definitely when we first started the clinic in 2020, lots of women were coming to us saying, my GP won't give me HRT. And now it's very much like, my GP's excellent. I'm getting HRT, but I just wanted a bit more of a chat, or I just wanted a bit more of specialist knowledge. So it's really changed in the last 5 years.
That's good to hear. And I think there's also a lot of awareness around how you prepare for that appointment. I think there are some apps around that can gather symptoms and help you present those symptoms to GP. Is that right?
Yeah, there's millions of apps around. So the one that many people use is the Balance app, but there's a real thing about symptom tracking now. And actually symptom tracking is extended to, so again, I'm sure you're finding the same in general practice. We're seeing a lot more patients in their 20s, 30s. People are a lot more sort of aware of their health now. And so we're getting a lot of women who are tracking their symptoms. So tracking their menstrual cycle. So now when I see young women in clinic we see lots of, people like things like PMS and as well, they will whip out their app with something like Clue or Flow, which has got all their symptoms on and all their menstrual cycles. So, but Balance is the one that a lot of women will use for menopause. There are lots of other ones available as well. And it does help in perimenopause, I think, to see if you're feeling, some symptom the whole way through the month and it isn't changing, then it's potentially, it might be what we might be looking at another cause. If your symptoms are varying with your cycle, then definitely there may well be a hormonal component to that. Mm. So it's an art, not a science, perimenopause, definitely.
I think in medicine in general isn't it? And listening to you, I was thinking about tracking symptoms. Actually, it's really useful for lots of medical problems, actually, isn't it? To write down your symptoms, because our recollection is not as useful as when you see it on a page and can start to see patterns and other things that can be interacting to cause all symptoms. I'm interested to follow up on the alternatives to HRT because some of the questions I get are more specific, and you'll know some of those specific questions, but things like the ones with phytoestrogens, so plant-based estrogens like black cohosh, red clover, and also I've had patients saying sage has done it for me. Yeah. I know there's no evidence behind them, but what are your thoughts around a take-home message about what people could safely try and maybe should be thinking about that might not be safe?
Yeah, no, absolutely. So the ones that there is some mild evidence for are these things called phytoestrogens. So phytoestrogens are plant estrogens. They're found in things like soy and tofu, and linseed. So there are various things that you can get them from diet. And there are also supplements. So any kind of, bog standard menopause supplement you get will have phytoestrogens in it. So red clover is one of them, black cohosh. There is some mild evidence that these can help with symptoms. What is really important to know, though, is that we don't recommend these for women who've had breast cancer, because we know they have an estrogen-like effect. So that is one set of women so we do lots of work with the Cancer Centre in Brighton, and we go and do lots of talks for them. And that's a question that always comes up is, can I take phytoestrogens? And the answer is probably not. So sage, absolutely. I've had women absolutely swear by sage for hot flushes. Magnesium, a lot of women take for sleep. And definitely we see, so one of the doctors who works with us at Myla has a specialism in migraine, which 30% of women get migraine in perimenopause. It's hugely common. And they do at the National Migraine Centre recommend magnesium for that. So those, I suppose, are the most common ones that we see. A lot of people take collagen for their sort of skin and joints. Again, I'm not seeing any convincing evidence about that. But again, some women swear by that.
Thank you. Thanks. Yeah, it's such a minefield, really, isn't it? So what are the risks? Maybe just to follow up on the breast cancer link, because there is a link there with some forms of HRT in that. Can you expand on that and also maybe touch on some of the other risks of HRT?
So what we know from this big trial, the Women's Health Initiative trial, is giving women, so there are two components to HRT. There is estrogen, which we give for the symptoms. And then if you have a womb, you have to take a progestogen to protect your womb from the estrogen. What we know is that if a woman takes HRT using an artificial progestogen, so that's something, even the Mirena coil or something like Everol Conti, has an artificial progestogen. If a woman over 50 takes it for 5 years, they have an increased risk of breast cancer of 4 to 8 extra women in 1,000. So if you look at what we call the absolute risk is absolutely tiny. So 992 women in 1,000 who take HRT for 5 years will not develop breast cancer from their HRT. Now, with the newer type of progesterone, which is progesterone, which people might know as Utrogestan, which is the most common brand, but lots of other brands are now being prescribed. That's what we call body identical progesterone. So that is identical to the progesterone that women make in their bodies when they're ovulating. And we think that taking that for 5 years does not increase your risk of breast cancer. So we've got a big trial that shows that. After that, we know the risk does increase with time, but we don't have much data, so we don't know how much. But this needs to be balanced against the fact that HRT for many women enables them to sleep and work and function and have relationships, that it reduces their risk of heart attack and stroke while they're taking it, and that it also reduces their risk of osteoporosis and hip fracture. So these risks need to be balanced, and it's generally accepted now that for 5 years, at least the first 5 years, the benefits of HRT for almost all women will outweigh the risks.
Thank you. That's crystal clear. And women with breast cancer, just explain why we'd recommend not to.
Yeah, so this is really hard. So breast cancer is a really common cancer. And in our clinic at Myla, we see lots and lots of women who've had breast cancer. And one thing that we would say for women who have breast cancer is do not give up hope. There is a lot of things that we can do for symptoms. And what we do is we work at symptoms one by one, essentially. We just, rather than HRT, which is a sort of blanket, yes, it will sort out all symptoms, we actually go much more carefully through all of them. There's lots of things we can do. So what we know is that many breast cancers have got estrogen receptors. So after you've had breast cancer, the treatment that you're given, essentially, well, there are different types of treatment, but if you're postmenopausal, you'll be given treatment to wipe out any estrogen in your body, which is called an aromatase inhibitor. And these put people into a sort of ultra menopause. They can often be really, really difficult to take, and they can get really nasty symptoms. And so we know that giving these women estrogen is going to be counterintuitive. So we're trying to not have estrogen because we wonder whether giving them estrogen might increase the recurrence of the cancer. Now, actually, the evidence that it does increase recurrence is actually not that great. So some women are taking HRT after breast cancer now, but only in a specialist context with the sort of lots of specialist intervention. But for most women, they don't want to. And for most women, there are lots of medications that we can give that can help their symptoms.
Thank you. And I got another question about topical estrogen. So I suppose we're not talking about the same group of women necessarily now, but I see quite often more elderly women suffering with recurrent urine infections and things like this. And in my simple brain, one of the best treatments being almost a topical HRT. Do you want to expand on that? Because I think that's something maybe not as known about.
Yeah, I absolutely agree. And this is something that, again, if you look at how much we've neglected this over the years. So, I mean, even our local urologists, specialists were not really prescribing this until a year or two ago. So this is not HRT. This is what we call topical local estrogen that's put into the vulva, vagina or bladder. So we know that although most symptoms of menopause will improve after 5 or 10 years, the lack of estrogen to the bladder and vulva and vagina actually just carries on getting worse with time. And so it can start very early. So even women in their 40s and 50s, we can see having painful sex or vaginal dryness or urine infections. But actually what happens is through time, it progresses. And often with women in their 70s and 80s, we see a lot of women at the Nuffield who've got issues with either urinary incontinence or a horrible feeling of needing to pee all the time, recurrent urine infections, pelvic pain, painful sex, itching, all of these things, and often using vaginal estrogen, which is really safe, doesn't go into the bloodstream, and as far as we know, can be used safely long term. It's a no-brainer really, and it's often difficult trying to convince women because they say, oh, I went through the menopause 20 years ago. This isn't menopause. And often the other thing is that it's often difficult to convince them that this isn't HRT. So it doesn't have the same potential risks, but it's incredibly useful. And in fact, one of the consultants who trained me said, all women should probably be on this after 50 for life, really. But actually, definitely women who are having symptoms. And it's about them recognizing that their symptoms are treatable. And it's amazing. You give it to women and suddenly they're not getting up 5 times a night to go to the loo or coming into the doctors every, few months with a urine infection. It makes a huge difference.
Thanks for expanding on that. I find one of the difficulties is also convincing because for many years, some women might have been having their regular antibiotics or even on an antibiotic long term to try and prevent it. And you test their urine and it shows bugs, but actually over the age of 60, it's quite common to see that anyway. And ultimately starting this has been transformational for them, hasn't it? Sometimes?
It really has. And a lot of this happens because I talk to women about it in my clinic who are 50 and they go, but my mum gets urine infections all the time. And then through them, we get their mum started on it. And then a year later, suddenly. So we know that it reduces and it's in the NICE guidance, it reduces the rate of recurrent UTI by 50% in one trial, which is a huge amount. And also, as we know, as GPs, urine infections can be incredibly dangerous to older people. They can end up being admitted to hospital. So definitely when we do talks at our local hospitals, it's the geriatricians who are really interested in this. They're the ones who are sort of saying, wait a minute, should we be giving these to all our patients? And we're going, well, actually there is a really good case for it. Yes. And it can be just put on in a cream. They're a bit fiddly, but for older women, we say just put the cream on a finger and put it on rather than using applicators. Or there's a little ring that you can put inside the vagina that stays there for 3 months at a time, which is very easy to use and can be changed by the practice nurse. So it's all sorts of things.
Great. We mentioned earlier a little bit about anxiety, brain fog, depression being really common experiences. Another one I've come across is almost kind of muscular pains and things as well. I know that intertwines with that vitamin D deficiency. Is it another problem altogether? How can we manage some of these symptoms? You mentioned, picking things off one by one for people who can't use HRT. So what if someone doesn't want HRT? Give us a flavour of how we approach some of these other symptoms in other ways.
So it's really difficult. And I think one of our strengths as GPs, isn't it, is this is what we do. We see people with 12 potentially unrelated symptoms and try and work out what's going on in their lives and what's causing them. And the question always is this life or is this hormones or is actually with most women a combination of the two? So we know that for some women, anxiety is the most common mental health symptom that we see. And a lot of the mental and this thing called brain fog. So brain fog isn't really a medical term. It's a lay term. And it's sort of what women describe it as this feeling that you're sort of wading through treacle, that your mind just isn't making the connections anymore. And if you're working, like a lot of the women we see, in a job which requires you to be cognitively able, that is a real difficulty. we know that brain fog, interestingly, is more common in perimenopause due to these real massive fluctuations of hormones that are going on. But we also know all of this is really impacted by lack of sleep. And Zoe Shadell, who's my other half at Myla, the other menopause specialist, is a specialist in sleep. We know that 30 to 40% of the women we see, at least, have sleep disruption. And this, as we know from being GPs, sleep disruption makes your anxiety worse. It makes your brain fog worse. It sort of makes everything worse, really. And then so often what we really try and do is to concentrate on sleep. So if women don't want to take HRT for sleep, we know it can be really effective. There's something called CBTI, Cognitive Behavioural Therapy for Insomnia, which I don't know if you can access it in Eastbourne. We've got the East Grinstead Sleep Clinic. I think the queue for it is several years. So we signpost people to apps. There's one called Sleepio and another called Sleep Station. Both of these are validated evidence-based apps to help with sleep. So that's for sleep. For anxiety, again, the bog standard CBT and then medication. So, and also just support from your GP. The GPs are great at managing anxiety. That's what we do. So we would definitely tell people to work with their GPs on this.
Thank you. Yeah, on sleep, just so people are aware, you can technically get it through Health in Mind locally, but yeah, getting it in reality is often a challenge. We also do that through SDHC. Miriam Malik, who has been on other podcasts, does CBTI as well for sleep problems. In terms of the workplace, we've touched on a little bit. Again, before checking in here, what can employers do to make workplaces a better place to support people during that transition?
So, this has been a really interesting thing. And so we do lots of talks in workplaces. So we were asked first by patients to come in and talk to their workplaces. And now we do this and we've talked to a lot of the local NHS trusts and that kind of thing. And it's part of this whole movement towards well-being at work, which for people who work in the NHS is always a bit of a surprise. But actually in other workplaces, people are very much want their employees to be well and they support them. And so and this is really interestingly being pushed by sort of millennials and Gen Z who want their workplace to look after them and they want to have health information in the workplace and they want them to be supported. But definitely menopause, because the fastest growing group economically in the workplace are women in their 50s for all sorts of different reasons. And it's the first time that women in their 50s has been working at a really high level. It's social change sort of over the last sort of 20, 30 years. And so I think workplaces have begun to realize that actually they don't want to lose this experience from the workplace. And there's a brilliant study done by the Fawcett Group, and it showed that 1 in 10 women had left a job in their 50s due to menopause, which is enormous. And definitely the older women that I'm seeing in clinic in their 60s and 70s went through menopause at a time when no one was talking about this. And what we see is this cycle of poor sleep, anxiety, loss of confidence, retreat from the workplace. People don't take on that promotion. They don't, volunteer for the presentation. They feel that they can't do their job. And then what people do is they just retreat. They lose their confidence. They leave their job. They don't think they can do it anymore. So what workplaces are doing is firstly being aware of this. So having education within the workplace, but also many workplaces now have a menopause policy in terms of how to support women who might be having menopausal symptoms at work.
Thank you. It always fascinates me to listen about that generation, I guess, because I also hear that if you employ somebody who's in their late 40s, 50s, they're much more likely to stay than, employing someone in their 20s. So it's such an investment, isn't it? And I think a statistic I've heard, I don't know if that resonates with you, that for every pound a workplace spends on improving health and wellbeing, they probably get a return of about £10.
Yeah, absolutely. We've heard that too. And if you look to the evidence for investing in your workplace and making your employees feel supported, it's huge. You get better productivity, you get less absence. The evidence is really there about investing in your employees. And also, these are women who you don't want to lose from the workplace. They're really experienced. They've often been there for a long time. They work hard. They know what they're doing. And you don't want them all leaving because they don't feel supported. And it's not rocket science, really, is it?
No, absolutely not. I guess we're transitioning as a population almost from saying we expect the NHS just to look after us to let's actually take some control of it as a broader society, really. Maybe. I've been listening out to try and think, what is the take-home message that you're bringing over? And I'm trying to guess it. I wonder if what you're saying is, look, don't suffer in silence. This is something that can really be treated incredibly safely and incredibly successfully. It might take some time to sit down with somebody to explore your symptoms, but goodness, don't suffer in silence. Is that the take-home message, you think? What?
Yeah, exactly that. I think there's really is still we know that the people who are accessing menopause care tend to disproportionately be white, professional, middle-class women. And there's a whole many groups of women out there who are not accessing care for all sorts of reasons. So sometimes it's cultural, sometimes it's this feeling, well, what can they do about it anyway? Sometimes it's still a lot of fears in some communities still about HRT and its safety. And what I'd really encourage women who are experiencing symptoms to do is to go and talk to their GP, or it's not just GPs, is it? Or the person in their practice who does menopause, because there's no need. What's been really harmful is there's been this thing online of like, oh, GPs are rubbish at menopause. They don't care. Don't even go. And that's obviously driven a lot of people to go privately. But actually, the majority of GPs that I teach and that we support with menopause are brilliant, and they really want to learn and they really want to help women. So I would say if people are suffering with the symptoms, then please just go and talk to your GP.
Thank you. And just to touch on something there, you said some of them aren't GPs, and certainly in my practice, we've got an advanced nurse who does a lot of this, and she's absolutely fantastic. And I guess just urge people to have their minds open as to who's going to help them as well.
Absolutely. I always say, so when we're doing talks to patients, we say, ask the receptionist. So the receptionist will always know who the best person is to see. And then I'd say, like you were saying about reading up, I would say, like you said, we can't expect the NHS to do everything. People do have to take some responsibility. So it's a really good idea to have a look at Women's Health Concern website before you go. Watch some videos on YouTube about menopause. There's millions of them. Have a little bit of an idea of sort of what you want to say. The other thing we always say is to write things down, because we know that what we see is that you've only got a short time usually with the clinician. Often women, by the time they go and see the doctor or the nurse, they haven't slept for ages. They're feeling really anxious. They've been told on the internet that their GP is going to be really unfriendly. They are really, they come in and they just cry. They're just so, they're so overwhelmed by all of it. So what we say, for instance, on our website, we've got a symptom checker, but there are loads of symptom checkers available. We say download it, write your symptoms, tick all the boxes, and then go along and then present your GP with a kind of a really succinct story about what's been going on, and then they can help you much better.
I think that really can help people feel more listened to too, because I think what we're not very good at as GPs is helping people feel listened to. They come with such an array of symptoms, and what we do quite tacitly is, as you said earlier, kind of start to group them together. One of the downsides of that, I find, is people think you're not listening to, the million symptoms that they've got. And I guess what we're automatically doing is summarising that a little bit, and in the process, sometimes people feel quite unheard, don't they? And I do think that can help.
Yeah, I really do. And I think I think there is a history throughout, centuries of women not being listened to and not feeling heard. And again, I don't think a lot of the time it's not actually out of malice. It's simply because we're all working in a system that is under an enormous amount of strain. People are busy and they are stressed, and women don't feel listened to. So again, by preparing what you're going to say and then having things written down so that if you're feeling emotional, which a lot of people are, because we know that the time people come and see us is when they're at their absolute worst, where things have got really bad. But having something down that you can look at, or bringing a friend with you, or anything like that can help you, it usually makes the consultation a lot more productive.
Yeah, thank you. Now, one thing that really bothers me about prescribing HRT is products going out of line. And the last guest on our podcast was a pharmacist, and we came up with a question being like, what advice do you have about when one product's not available and how you switch? And
and it's an absolute nightmare. So currently Estradiol, which are the teeny weeny little patches that everyone loves, which have been sort of going in and out of stock, they are currently out of stock. So at Milo, my admin staff, and again my pharmacists in Lewis are just spending hours and hours trying to sort this out. It's really really, really difficult. But also it's really difficult for women because often, again, when they've presented to get HRT, they are absolutely at the, end of their tether. They're feeling that life is unbearable and they are desperate to stop these symptoms happening again. The good thing is that now pharmacists are allowed to substitute different patches. So at least those are, you can get something that's the same. It might not be quite as comfortable. It might be a bit bigger, but it is the same. The other things, the things that went out of stock a few years ago, which was the gel and the tablets, luckily that's fine. They've built another factory. Those haven't been a shortage for ages. So, but it is really horrible for women and also it's hard work for our pharmacists trying to sort it out.
I bet. Look, it's been fascinating talking to you and actually makes me kind of want to do more in this area because it's such a satisfying subject to do well, isn't it?
Yeah, it's brilliant. You can make so much change to people's life. As I say to women, they will say, thank you so much. I say, look, I'm just the supplier of some particularly good drugs. It works really well. But when the HRT is also supported with the lifestyle advice and the mental health support and all these other things, I think we can make a huge difference to people's lives.
I think you're underselling your ability to communicate with people, listen and share some positivity to them. But thank you very much. It's been really inspiring to talk with you, and I can see how much you must help the people that seek your advice.
Well, thank you very much for inviting
me. You've been listening to the Health and Wellbeing podcast, where today's focus was on the menopause revolution and the complexities surrounding menopause treatment with Dr Olivia Hum and me, Dr Nick Harvey. For more information and resources, check out our website, sthc.org.uk. If you've got any feedback or suggestions for future episodes, please email us at sthc.feedback@nhs.net. Join us for our next episode, where Dr Haider Al-Shamar will be coming on to discuss the provision of early dementia diagnosis within our community. Please take a moment to subscribe to help support us in empowering others with their health and well-being.